Hello everyone, this is my presentation of Dale's Charlson Index Project. History of Diagnosis-Based Prognostic Indices. Original Charlson Index. It was developed in 1987 and it developed the method of risk determination of mortality based on the patient's comorbidity. This had 19 categories. Comorbidity score was based on the sum of all scores. The higher the score was, the higher mortality rate. Dale's Charlson Index. Modified from the original Charlson indices in 1992, this version assigned a score to various chronic medical conditions and the score sum was used to predict long-term mortality. Two original categories, leukemia and lymphomas, were combined into any malignancy category. Therefore, there was only 17 categories. Romano's Charlson Index. Modified from Charlson and Dale's indices in 1993, it provided more accuracy by indicating the assignment of ICD-9-CM codes to the Charlson Comorbidity Index was not straightforward. This led to the development of calculating based on the type of data and its availability. This was used with administrative data, and this also had 17 categories. Utilization of indices in EHRs in clinics. Charlson Index. The Department of Veterans Affairs had a stroke study and used this in 9 VA hospitals in 1995 to 1997. It was used as a measurement of comorbidity for the varying outcomes of ischemic stroke patients. Dale Charlson Index. Two teaching hospitals in Boston, Massachusetts used this in 2007 to 2012. It was used to assess long-term outcomes in the intensive care unit patients. Romano Index. National Registry of Atrial Fibrillation. They used Medicare data in 1995 to 1999. It was used to predict mortality with the atrial fibrillation in comparison of a chart review index. In this slide, I will be going over the data cleaning. We removed patients who had an age at death before age at diagnosis, which are known as zombies. We removed patients who had a date of birth that is impossible, which are known as vampires. These are patients who had an age at DX of less than 0 and greater than 99. We also removed patients where the ICD-9 and the age at DX is null. Then we made a new table and we moved the clean data into that table. And the results of this: number of records were over 17 million, and then the number of patients were a little over 800,000. For the data scoring, we used the Dale's version of Charlson Index, which is the image on the left. Each category is then assigned to the designated score weight based on the index's ICD-9 codes. This will allow patients to be assigned to their overall score based on their categories of diagnosis, and in the code on the right, all the categories are listed and then all the scores are aligned with their category. And then we also make a score column in which all the scores will be calculated for each patient. So for the Charlson accuracy of index, we have to make sure that the sample cutoff is made, and then we also have to find the sensitivity and specificity to make the graph and calculate the area under the curve. So the closer the area is under the curve to 1, then the more accurate the data is. The area under the curve that I found was 0.0617900149605048. And the images on the right just show the cutoff, sensitivity, and specificity, and then the graph and the code. How to improve accuracy. Make sure the data is correctly cleaned before using. Use the most updated index because diagnosis score weights can be reassessed or updated. Use a better cutoff value to have a more accurate area under the curve. These are my references. I hope you guys enjoyed. Thank you.